Okay, so hello all. I'm going to be talking about just giving an overview of breast cancer for the primary care physician. I'm going to spend a few minutes talking about the epidemiology of breast cancer, prevention and screening guidelines, classification of breast cancer, management, and a few minutes on breast cancer disparities. I have nothing to disclose today. Before I actually start the presentation, I'm going to put up a question that I hope you all put your answers down. I'm also going to ask the question at the end of the presentation. And for those who got the question wrong, hopefully you're able to answer it correctly at the end. So the question is, which one of these patients should get genetic or BRCA mutation testing? First patient is a 59-year-old female with newly diagnosed hormone receptor positive breast cancer. Next patient is a 42-year-old female with newly diagnosed hormone receptor positive breast cancer. Next patient is 59-year-old female with newly diagnosed triple negative breast cancer. And finally, an 80-year-old male with newly diagnosed breast cancer. So breast cancer is the second most common cause of cancer deaths in women after lung cancer. However, the death rates have decreased by about 2.5% per year since the 1990s. This is for white women, and about 1% per year in Black women. We think the decrease we're seeing is due to early detection and improved treatment. In terms of the incidence of breast cancer, it's highest in North America and Northern Europe, and lowest in Africa and Asia. This is a nice graph just showing the breast cancer incidence and mortality in the US. And as you can see here, the incidence is actually higher in white women in the pink compared to Black women in the black. However, the mortality is higher in Black women when compared to white women. The reasons are complex. A lot of it has to do with genetics, risk factors, access to care, a few other things that I'll, make a note of at the end of this presentation. This is another graph showing the same thing. However, it compares other groups of women as well. And you see the death rates are still the highest for Black women, followed by white women, Hispanic women, and Asian American women have the lowest incidence of breast cancer in the US. In terms of risk factors for breast cancer, gender, if you're a woman, your risks are higher than if you're a male. Age, the older you are, the higher your risk of breast cancer. 85% of breast cancer diagnoses occur after the age of 50. A family history of breast cancer increases your risk. Prolonged use of estrogen and progesterone replacement, as well as endogenous hormonal factors such as early menarche, late menopause, nulliparity, and higher BMI, which also increases your endogenous estrogen. Prior radiation to the chest wall area, where there's been some radiation to the breast as well, in patients with a history of maybe lymphoma who've had to get radiation in the past, also increases your risk of breast cancer, as well as having dense breasts. Now, there are genetic conditions associated with breast cancer. We all know about the BRCA1 and 2 mutations. They're both tumor suppressor genes involved in DNA repair. They're autosomal dominant inherited with variable penetrance. It's more common in triple negative breast cancer, which is important to note because triple negative breast cancer is more common in the Black population. However, it's important to also note that besides BRCA1 and 2, that there are other mutations associated with breast cancer, such as PALB2, CHEK2, P53, P10. So I just thought it was important to make a note of that as well. I also wanted to note that even though most breast cancer patients are women, males do get breast cancer. It's rare, but it does exist. In 2020, the expectations are that over 2,500 men are going to be diagnosed with breast cancer, and over 500 of those men are expected to die from the disease. So it's something that should be noted as well. Some of the risk factors for breast cancer in men are Klinefelters, having liver disease, estrogen-related drugs such as spironolactone, and having a BRCA2 mutation all increase the risk for breast cancer in men. Now, what do we do in terms of prevention? We focus a lot on screening because that's probably the best tool we have, but there are ways to actually identify patients that are at a high risk of developing breast cancer. and there are things we can potentially do about that. So this is a breast cancer risk assessment tool. It's called the Gill model, which you can find online. And basically it imports a bunch of questions into a calculator and calculates the risk of a 5-year risk of developing breast cancer. For patients with a risk of 1.67% or higher, they're considered high risk, and there are certain things we can do about that. So some of the questions that are asked and imported into the risk tool are the woman's history of breast cancer or DCIS, the presence of a BRCA1 or 2 gene, the patient's age, age at menarche, age at first live birth, other first-degree relatives with the breast cancer, prior history of a biopsy, how many biopsies, and the race and ethnicity. So it's all imported into this calculator, and it helps calculate the risk. Now, once you've identified a patient who's high risk, what can you actually do about that? Well, we have studies showing that chemo prevention, particularly with tamoxifen or raloxifene, that are selective estrogen receptor modulators, decrease the risk of invasive and non-invasive cancers in this women who are considered high risk. So this is a graph showing the study that was done in the late 1990s, the NSABP1 trial, which had women with the Gill model high risk score. They had a group on placebo, they had a group on tamoxifen. And as you could see here, the risk of invasive breast cancer and non-invasive breast cancer over here was higher in the patients who were on placebo. The STAR trial also looked at raloxifene versus tamoxifen and basically showed that they both are equally effective in preventing breast cancer in patients that are considered high risk. The question is, why don't we do this more often? And I think a lot of it has to do with many times that we're presented with a person with the high risk of breast cancer, they tend to be younger women at reproductive age who maybe want to start a family, and being on tamoxifen and raloxifene are not recommended because they are teratogenic. So we don't use this very often, but definitely this is a way of preventing breast cancer in patients who are high risk, who maybe have no plans to have children or are very motivated to find ways to risk reduce. So it's just something that I think is important for us to be aware of. And then generally what we all know about and what we all recommend is screening. Currently the guidelines are, the American Cancer Society guidelines are that mammograms should be done every 1 to 2 years starting at the age of 40. This is a bit controversial if you think about what the United States Preventative Services Task Force recommendations are, because they recommend mammogram every year starting at the age of 50. The concerns are that we may be overdiagnosing patients, we may be forcing patients to have biopsies, causing distress, causing emotional, causing these patients to be overwhelmed by having biopsies for lesions that are probably benign. And that concern is definitely warranted and valid. However, particularly when we're dealing with Black women who have higher incidence of triple negative breast cancers, which also occurs in younger women and is the most aggressive and most difficult breast cancer to treat. I think it's important to screen these patients at an earlier age than the age of 50, as recommended by the United States Preventative Services Task Force. So we follow the American Cancer Society guidelines, which is getting mammograms every year starting at the age of 40. Then the question that I get from a lot of patients is, why can't I just do an ultrasound? Why do I need to do a mammogram? Because the mammograms are not very comfortable. However, mammogram is the modality of choice for initial screening. And the reason why is the ultrasound really cannot image the entire breast at once. You don't get to see the whole architecture of the breast if you're performing an ultrasound from the get-go. A mammogram shows the whole breast architecture. Then the breast ultrasound we're able to use that for a diagnostic spot check of areas that have been deemed abnormal on the mammogram. The breast ultrasound really helps to distinguish between a fluid-filled cyst and a solid mass in the breast. So a mammogram is always the first imaging modality for initial screening. Now, how do we screen patients who do have a BRCA1 or 2 mutation? The recommendations are for monthly self-exams beginning at the age of 18, frequent clinician breast exam at age 25, mammograms every 6 to 12 months beginning at the age of 25. And because these women are younger and tend to have more dense breast, an MRI should be considered because the mammogram is not as sensitive or as specific in this younger patients with dense breast. It's important to note, however, that if a breast MRI is being done, it needs to be done in combination with a mammogram, not instead of a mammogram. Now, who should get BRCA genetic testing? Well, the current guidelines are, or recommendations are, that patients who've been diagnosed with breast cancer under the age of 50, patients with triple negative breast cancer diagnosed under the age of 60, patients with 2 or more primary breast cancers, history of, or patients with an invasive ovarian or fallopian tube cancer or primary peritoneal cancer. Any male breast cancer should get BRCA genetic testing, and patients with any hereditary breast or ovarian cancer associated cancers, regardless of the age of diagnosis, if they are of Ashkenazi Jewish ancestry. So these are the patients that we should be checking for a BRCA genetic mutation. Now, how do we classify breast cancer? There are multiple ways, but generally we use the immunophenotypic classification, which is basically looking at receptors on the breast cancer. We're doing immunohistochemistry staining, looking for estrogen receptors, progesterone receptors, as well as HER2 receptors. So when we talk about a patient being hormone receptor positive, it means they're either estrogen or progesterone receptor positive. If they're HER2 positive, it means they stained positive by IHC, by immunohistochemistry, or by FISH, that they've stained for that on the breast cancer. And the patients that are triple negative are the patients who do not have the estrogen receptor, progesterone receptor, or the HER2 That's what it means to be triple negative. And you can have a whole combination of being ER positive, PR negative, HER2 positive, ER negative, PR negative, but those are very important because they help us classify the breast cancer and also helps us in figuring out how to manage the patients. We have the molecular classification, which is really just used for research purposes and for academic conversations, but we don't generally use it in the clinical setting. Now, breast cancer is staged like most cancers are staged using the AJCC tumor node metastasis. I'm not going to go over this. I just wanted to put a picture showing that we do use the standard TNM way of staging breast cancer. Why are all this important? Why is it important to stage? Why is it important to classify this breast cancers? And it's very important because the need for and the choice of systemic therapy that we use really is based on the clinical and pathologic features of the tumor, whether it's the tumor size, the grade, the nodal status, as well as the tumor stage. So those are all very important for us to make treatment plans on this patient. In terms of surgical management, and I think there would be a different talk from one of the breast surgeons, but this is just to get a sense of what the lingo is. When a patient's being recommended for a simple mastectomy, it's just a surgery that takes out the breast, and that's it. A modified radical mastectomy basically is a simple mastectomy as well as axillary lymph node dissection. So the axillary lymph nodes are also dissected, and the pectoralis lining is also removed in this types of surgery. So simple mastectomy is basically the removal of the breast, all breast tissue without lymph node dissection. Modified radical mastectomy is removal of the breast as well as the axillary lymph node dissection. When we talk about lumpectomies, it's really just a surgical, it's basically just surgery taking out the area where the tumor is located, as you see in this picture. It's important to note that a lumpectomy is essentially the same thing as a partial mastectomy, is the same thing as a segmentectomy. I guess when you mention segmentectomy, is a segment of the breast that's being taken out, but patients do get confused, and sometimes providers do get confused with the lingo. But if it's not a mastectomy that's taking out the whole breast, then it's a breast conserving surgery, which is a lumpectomy or partial mastectomy or a segmentectomy. This is just a graph showing that we do not necessarily need to perform mastectomies on our patients. The goal is always breast conservation if that's possible. This shows disease-free survival, distant-free survival, and overall survival in patients who had a total mastectomy versus patients who had a segmental mastectomy, which is the same thing as a lumpectomy or a partial mastectomy with radiation. And you could see that even though there's a separation of the curve, it wasn't really statistically significant. Both patients essentially did as well. So total mastectomy and removal of the whole breast tissue is not required in all patients. As long as these patients get a radiation with their lumpectomy, the disease-free survival, distant-free survival, and overall survival is essentially similar. This shows the importance of radiation in patients that do get lumpectomy. And you can see the incidence of recurrence in this patient who had a lumpectomy without radiation versus patients who had lumpectomy and radiation. And this is at 20 years post-surgery. So for patients who do not want radiation, then we recommend that they have a total mastectomy because the radiation definitely reduces the incidence of recurrent events of breast cancer. Now, there are some contraindications for breast conservation with the radiation. Patients who've gotten prior radiation to the breast or chest wall are unlikely to be able to get additional radiation. We can't radiate pregnant patients. Patients who have widespread disease may really require the whole breast to come out if we can't go to all the different areas where the disease is. There are some relative contraindications. Patients who have active connective tissue disorders like scleroderma or lupus that have active disease, radiation may actually flare up those connective tissue diseases, so we may not want to radiate those patients. Patients who have a T4 disease, which is disease that's involving the skin, may benefit more from just having a total mastectomy, but that's not always the case. We go on a case-by-case basis, and I think it's just important for us to be aware. So this conversation are being had with patients who really want to preserve their breasts, and just having the conversation that that's a possibility, and our goal really is always to preserve the breast. I think in the past we've always just recommended mastectomies for patients with BRCA1 or 2 mutations, or younger patients, premenopausal patients with breast cancer, but it's a relative contraindication. Once again, it's on a case-by-case basis. So in terms of systemic treatment, we have chemotherapy, which making a decision as to whether chemotherapy is required or not requires a risk evaluation. We look at prognostic factors in this patient. We look at the receptor status, like I mentioned earlier, the tumor grade, the tumor stage, to make that decision. Not all patients require chemotherapy. Some patients are able to get treated with just anti-estrogen therapy, and some patients don't actually require anything else after their surgery plus minus radiation. We have genomic testing such as the Oncotype DX and the MammoPrint, which are also additional tools that are available to risk stratify patients and figure out who's going to benefit from adjuvant chemotherapy or not require chemotherapy. In terms of do we give the chemotherapy adjuvant, which is after surgery, or neoadjuvant, which is before surgery, it actually really doesn't matter. You can see this forest plot here looking at death, disease progression, distant recurrence, and local regional recurrence. In patients who required chemotherapy and got it before surgery or after surgery, survival, progression, recurrence were all pretty even. And this is important for patients who are very eager to have surgery to take the breast cancer out, who require chemotherapy, that we may be recommending that they get chemotherapy before surgery. It's important for them to know that delaying surgery, if they're actively being treated for their breast cancer with chemotherapy, is unlikely to change their survival. So I have that conversation a lot with patients. And if it's, if we're able to proceed with surgery first and treat later, and with chemotherapy if it's needed, then we do that. But more and more for patients who require chemotherapy, we're finding ourselves wanting to give the chemotherapy before surgery because it really allows us to assess the response to the chemotherapy, as it's helping us make additional treatment plans and additional decisions after surgery. In terms of other systemic therapies, we have endocrine therapies such as tamoxifen, which is a selective estrogen receptor modulator, and basically just competes with the estrogen for the receptor. And it's just, we use that primarily in premenopausal women, but it's also used in menopausal women. We have the aromatase inhibitors, which we use in our postmenopausal women. We have anastrozole, letrozole, and exemestane. They're also great drugs with minimal side effects. Patients sometimes complain of arthralgias when they're on it. It does, however, increase the risk of osteoporosis and possibly fractures. So we recommend all our patients take supplements with calcium and vitamin D, and often we'll actually give bisphosphonates or other bone modifying agents to reduce their risk of fractures. Both tamoxifen and the aromatase inhibitors generally cause hot flashes in many of our patients. So we find ways to help mitigate those symptoms, whether it's to dress lightly, to drink, cold liquids, stay in a room that's aerated with fans and air conditioning. Generally, they're able to manage those symptoms. Some patients, when it gets really bad, then we need to make some changes to their medications, or sometimes even give other medications to manage those symptoms. How do we follow this patient? Surveillance, really post-treatment, is we do mammograms every 6 months on the unaffected breast for the first 2 years post-treatment. Then we go back to yearly. We follow them with routine history and physicals. We do blood work such as CBCs and CMP, just looking for any other blood disorders that may have developed as a potential, side effect of chemotherapy. We do DEXA scans on the patients who are on the aromatase inhibitors, looking for osteopenia or osteoporosis. And sometimes we will check tumor markers. The role of tumor markers is actually controversial. Some medical oncologists check it, some don't. It's really operator dependent, but CA2729 and CA15-3 are the two tumor markers associated with breast cancer that we sometimes will follow post-treatment. And so just talking about disparities, and since this is, part of what this seminar is, breast cancer in Black women, as I mentioned earlier, and I showed the slide, that the incidence of breast cancer is actually lower in Black women. However, the mortality rates are higher, and it's probably very complicated. And I think it's important for us to be aware of the statistics and sort of find ways that we can contribute to narrowing the disparities that exist between Black women in the US and other groups of women who've been diagnosed with breast cancer. It's very likely that genetics plays a high, genetics plays a high role as to why Black women have worse mortality, because they have higher incidence of the triple negative breast cancer, which is the more aggressive breast cancer subtype. But even within the group where Black women are compared to white women with triple negative breast cancer, the Black women still do slightly worse. So obesity is another risk factor. So looking for ways to reduce obesity in the African American community is important. Access to care, access to tertiary institutions, particularly access to clinical trials, is also likely contributing to the disparities that we see. When you look at some of the clinical trials that are being churned out, and a lot of it with drugs that are used to treat triple negative breast cancer, you find that the percentage of Black women included in this clinical trials are very, very, very small. I think there was one study where it was about 4%, another was 8% of the patients with the triple negative breast cancer in that clinical trial. So it's important for us, as we're taking care of this patient, to make sure we're looking for avenues and we're looking for ways to have them plugged into institutions where they will have access to clinical trials. We need to do better with our screening. We do know that Black women are screened less in general. Some of it may have to do with the screening guidelines. Like I said, the U.S. Preventative Services Task Force is a little bit more conservative in terms of when to start mammograms. We follow the American Cancer Society guidelines, which is to start at 40. So I encourage you to start screening your patients earlier. And we definitely have lower rates of genetic testing, which are things that could, reduce the risk of developing cancer or cancer in another family member in this patient. So these are some of the things that we need to be aware of and looking for ways that we can really contribute to reducing the disparities that exist. Hopefully you all have your answers, and next slide shows the answers, and hopefully you learned something from this presentation. Answers are B, C, and D. So any man who's diagnosed with breast cancer needs to get genetic testing. Any woman who's less than the age of 60 needs to get genetic testing for triple negative breast cancer. And a patient who's under the age of 50, regardless of the breast cancer type, should also be sent for genetic testing. So those B, C, and D should be tested. A woman who's 59 with hormone receptor positive breast cancer is sort of the typical presentation and unlikely to be associated with an abnormal gene mutation. Okay. All right. Thank you.